So we are talking about pseudo-exfoliation syndrome. It is the most common secondary glaucoma, right? What story is almost similar to that we have learned in pigmentary glaucoma. So what is happening here? Let's understand. Make the diagram, please. So this time what is happening is, it is the dandruff-like material which is getting deposited. This is a dandruff-like grey-white fibrily material. This is deposited on the lens capsule, in the suspensory ligaments, at the back of the cornea, and the same dandruff-like deposits are going to block the trabecular meshwork. So story is same in pigmentary glaucoma, it was the pigments, whereas in pseudo-exfoliation syndrome, it is mainly the dandruff-like material which is blocking the trabecular meshwork. Leading to which type of glaucoma if there is a block in trabecular meshwork, all of you? It is secondary open angle glaucoma. Once you know this, that this time it is, let's write it. It is grey-white fibrily, grey-white okay, dandruff-like material. Okay, this is how you will describe dandruff-like material. Why this is, from where it is coming? It is mainly some abnormal extracellular matrix metabolism. So it is an abnormal extracellular matrix metabolism in the ocular tissues which is actually causing the release of these. So it's not a true exfoliation. That is why if you see, we are calling it pseudo exfoliation. It's not a true exfoliation, it's a pseudo exfoliation, right? So these dandruff-like material, what are the features, what do we see in the eye and how it is causing a problem, right? So first of all, why it is happening? We'll first talk about it. So it is generally associated with, point number one, with the, it is considered to be genetic. The gene associated is LOXL1. This is in chromosome number 15. So mainly the etiology, it is genetic in origin. The name of the gene LOXL1, okay, yeah, in chromosome 15. It is mainly seen in age group of more than 50 years. The biggest risk is it is causing open angle glaucoma, and because it is weakening the suspensory ligaments, it is one of the reasons of subluxation of lens. Then it can be a very big challenge during cataract surgery. Okay, so during cataract surgery, the lens suspensory ligament is so weak, the capsular bag itself is so weak that it's very difficult to retain the bag. When you are doing the cataract, the whole bag comes out. So it's very difficult to retain it, right? So we have to keep that in mind, and before operating any patient of the cataract, I should know whether he is a case of pseudo-exfoliation syndrome or not. And as I told you, because it is one of the most common secondary glaucomas, correct? So you will see it very commonly, so you should always look for pseudo-exfoliation syndrome in the pre-op patients, right? Especially for cataract. Okay, so once we know why it happens, and it is mainly of the gene, which gene is responsible. Also remember, it may be associated with some systemic diseases. So it can be associated with hearing loss, okay, and it can be associated with some heart problems, right? So with some serious disorders. Okay, now what are the findings? Very, very important. What are we saying? Let us draw another diagram to learn all the findings. So this dandruff, I'll show you the slides also. First, let us draw in for ourselves. So the dandruff-like material, where are we going to find? First of all, we said at the back of the cornea, right? SKPs, right? So these can be deposited at the back of the cornea, and sometimes it can be Krukenberg spindles, though it is less common than pigmentary, but yes, it may be spindle shape, then we call it Krukenberg spindles. When you look at the pupillary border, I am making a small diagram here to make you understand. So in the pupillary border, I can see the depositions like this, right? So here I will make the depositions on the pupillary border, right? So there is loss of pupillary ruff. At the margin there is a deposition of the dye. Then on the lens, okay, so it is deposited in such a way that there is a between a clear area which is called hoarfrost sign. Let us note down hoarfrost sign. Hoarfrost sign. Of course, in the TM, it is deposited in the trabecular meshwork and causing secondary open angle glaucoma. Right, all of you? And cataracts will be more common. Another important thing we have to know, when I am talking about systemic, you can write along with that only. Associated with hearing loss, with serious disorders. One more point please add here. It is seen, now this is little above your level, you may learn it, you may not learn it, but I am just giving some additional point here, that there is more homocysteine level in the plasma and aqueous humor. Okay, in these patients, more homocysteine levels in plasma and aqueous humor. And there is a folate deficiency, it precipitates faster. Okay, precipitates more in folate deficiency. Even if you don't learn it, I don't mind. This was a little extra point I just gave. Okay. Then once you know what are the findings and what the problem it can cause, why it happens, now how will we manage? It is almost the same way as pigmentary glaucoma. That is, I will give the treatment as medical, anti-glaucoma drugs can be given, or it could be very effective is argon laser trabeculoplasty. The main problem is in the trabecular meshwork. ALT is very effective. I'll talk about ALT shortly. Let's see the signs. So this is your dandruff-like material. Can you see that? All deposited like this, here and here, right? So the dandruff-like deposits here. Loss of it, the pupillary rough has all been lost, it becomes more smoother. Again, this dandruff-like material we can see here. I think it's absolutely clear, right? On the lens. Oh yes, how can we miss this? So there will be again more pigmentation in the trabecular meshwork and an extra line in front of the Schwalbe's line. I mentioned in pigmentary glaucoma also, this is what is called Sampolezzi's line. The arrow is showing here. So this anteremost is the Sampolezzi's line. It is also a feature of pseudo-exfoliation syndrome. So you can actually note down on your diagram where you have made the angle that we can get Sampolezzi's line. This is what it is showing you. We have learned this in the lens chapter as well. This slide is of subluxation of lens due to the weak zonules. So this one is your subluxation of lens. Okay. The third type of secondary glaucoma is lens-induced glaucoma. So because we have done it in the lens chapter, I'll take it very quickly. Lens-induced glaucoma, what did you learn? It could be phacolytic. We all know phacolytic is seen in Morgagnonian cataract. It is secondary open angle glaucoma. Since we are repeating, we'll move here quickly. Then it was phacotoxic due to trauma, T for tree, trauma. Again the lens protein blocking the TM, but this time the cause is trauma. We also call it lens particle glaucoma. Lens particle glaucoma. Correct? Due to mainly trauma. What was the third one? Phacomorphic due to intumescent cataract causing pupillary block. Phacomorphic. After that, phacoanaphylactic. I am writing here. Phacoanaphylactic. This is also called phacogenic, and if you remember, I had explained you very nicely that it is due to the immune reaction towards the lens protein. Okay, just remember that. So this is also called phacogenic. This is also open angle. Phacotoxic is also secondary open angle. But what about phacomorphic? We had done this. It is secondary angle closure glaucoma. Morphic will be secondary angle closure glaucoma. Come to the next secondary glaucoma, neovascular glaucoma. Give the heading neovascular. So we talk about neovascular glaucoma. Now what is the story behind neovascular glaucoma? Hypoxia, right? Basic pathology, it starts from hypoxia in the retina. So whenever there is a hypoxia in the retina, What is the reaction in the retina? Any hypoxia, then what is the reaction in your tissue? It is to compensate for that, there is neovascularization. The same is happening in the eye. So there is a neovascularization in the iris. And neovascularization takes place by release of mainly angiogenic factors. What are the angiogenic factors? Primarily we will learn vascular endothelial growth factor. Now what happens? This vascular endothelial growth factor manages to reach the anterior segment of the eye. So we are talking about the story, right? So when it comes to the anterior segment of the eye, now it is going to cause neovascularization of the iris, right? So any neovascularization in the iris is what is called rubeosis iritis. This is rubeosis iritis. Think yourself what next will happen. This is going to grow into the angle. What are the structures in the angle? We so very well know this. Trabecular meshwork, Schelm's canal. So when it is going into the trabecular meshwork, it is hampering the flow inside that, leading to open angle glaucoma. So initially it is open angle glaucoma, but you know any neovascularization will not be only blood vessels. It will always be associated with fibrous tissue. So that associated fibrous tissue contracts. When that contracts, that is going to close the angle. Closing of angle means you already know where there is a position and obliteration of this space between the iris and cornea. So please remember, initially neovascular glaucoma is an open angle and later it becomes angle closure glaucoma. Interesting? Yeah. So let's see the slide. So this is the slide that what is it indicating here? What is it showing? These are the new blood vessels in the iris, right? So we are talking about rubeosis iritis. So the question asked in your exam is treatment of choice of neovascular glaucoma. So you should first remove the root cause. And what is the root cause? Hypoxia in the retina. So if the root cause is hypoxia in the retina, what will be the treatment of choice? It is always pan-retinal photocoagulation. So we will always answer. Make a Q there, all of you. Don't forget to make a Q here. It is pan-retinal photocoagulation. Of course, we are going to give anti-glaucoma drugs to decrease the intraocular pressure. And meantime, we may also, along with this, go for some anti-VEGF. Mainly, it's an adjunctive treatment or measure to go for intravitreal injection of anti-VEGF. You want to write? Write it. Number 3. So, while we can also go for adjunctive treatment with intravitreal. So, when you are reading, when we are going to study retina, we will be discussing that how intravitreal anti-VEGF can be the treatment of choice in different conditions. But here we will first answer PRP, and intravitreal anti-VEGF is used as an adjunctive treatment. Okay? Again, we will take the details of anti-VEGF agents, bevacizumab, ranibizumab, and so on. We will discuss that in that chapter. Okay. That was your neovascular glaucoma. Important question was asked. Okay. We didn't discuss hypoxia when we are saying, you can write on this diagram, what can be the different causes. Again, we are going to learn a long list of the causes in retina chapter, but primarily the two major causes that should come in your mind immediately is diabetes mellitus, CRBO. Very, very common. Okay. So these are mainly the causes of your hypoxia. Chalo. Then we talk about which is the next secondary glaucoma. Give the heading, malignant glaucoma. Here malignant doesn't mean it is related to malignancy. No. Malignant term is used because it is resistant to the usual anti-glaucoma treatment. The patient is not responding. So we are saying malignant. It is also called, what is the other name? Ciliary block glaucoma. Also called ciliary block glaucoma. Okay, so first let's understand the pathogenesis, the story behind it. So pathogenesis says, what is happening after any intraocular procedure? There is anterior rotation of the ciliary body. When there is anterior rotation of the ciliary processes, it is causing ciliolenticular touch. That's why ciliary block glaucoma. So when there is a ciliolenticular touch, The aqueous, now we'll make the diagram and also understand. What is happening is due to this ciliolenticular touch, aqueous that is formed here cannot go anteriorly. There's a block. It starts collecting in the vitreous cavity. So main pathogenesis is that aqueous has started collecting in the vitreous cavity. There's a block. It cannot go anteriorly. So then think yourself, if it cannot go anteriorly and there is a block, do you also realize naturally the pressure is going to be more? Aqueous is started collected, aqueous is formed continuously. It pushes the lens iris diaphragm anteriorly. So when the lens iris diaphragm will become anterior, have you realized there will be not only shallow but very shallow anterior chamber. Don't go to the diagram, the space is to write, but there is a very shallow anterior chamber. And this very shallow anterior chamber is, after any intraocular procedure, one should immediately doubt and suspect malignant glaucoma. Okay? Let's see this slide. Okay, so this was related to the neovascular glaucoma, how the VEGF is going anteriorly. Now coming to malignancy, this is what is happening. What is the other name of malignant? I told you ciliary block, right? One more name, aqueous misdirection syndrome. So we can also call it aqueous misdirection syndrome. What is happening here? The aqueous is coming into the vitreous cavity. Okay, so do you realize how much pressure it can cause? And this is going to lead to shallow anterior chamber. How much shallow? Look at it. See, when you're looking the slit lamp, there's hardly any space anterior. This is the anterior chamber. Very shallow anterior chamber. Isn't it? Very dangerous condition, of course, if you don't manage. And the shallowing is all throughout. It's not like only it is at the periphery. It is all throughout. This is typical of aqueous misdirection. Okay, when I'm doing an OCT, again I can see it very clearly how this is. Can you see the shallowing here? Look at the shallowing, right? And there is a peripheral iris and corneal touch. Okay, so this is even more confirmed with OCT, but generally we don't need an OCT to diagnose this. Okay, right? So now we know what is malignant glaucoma, what are the name, how this is happening, right? And what is the cause? You will always answer after any intraocular surgery. Now I am telling you one exam question that they have asked you many times. So we will make a double Q. After which surgery it is most common? So we will write it is most common after trabeculectomy. It is more common after trabeculectomy. Take it? How will you manage? Treatment. The first line of treatment is always atropine. So many times the students ask me, ma'am, why atropine and what is atropine doing? So atropine is actually dilating the ciliary ring, right on. It dilates the ciliary ring. Now it is also, what it is doing, it's a cycloplegic. When the ciliary muscles are relaxing, do you realize what is happening? The zonules are all tense, pulled back. So when the zonules are stretched, it is going to pull back the lens. So that is helping in managing and opening the block. And once the block is open, we are not worried, right? So majority of the patients will respond with atropine. What are the two mechanisms I told you? Please note down. One is dilates the ciliary ring, and also because it is causing the cycloplegia, this cycloplegia, or you can say palsy or relaxation of the ciliary muscles, this relaxation of ciliary muscles will lead to what? Stretching of zonules, and stretching of zonules will be leading to, what do you say? That is pulling back of the lens, and the block opens. This opens the block. Now suppose the patient has not responded with atropine. What next I can do? There is one more non-invasive method that I can use Nd:ARG laser. Okay, you all remember the anterior hyaloid membrane? So we give this is called, and we make some few holes in the anterior hyaloid membrane, and what happens in that case? The aqueous is going to leak out anteriorly, and once this starts happening, the block will open. Okay, so we will say the second modality is Nd:ARG anterior hyaloidotomy. Hyaloidotomy क्या हुआ? Hyaloidotomy means giving the opening, making multiple openings in the anterior hyaloid membrane. What is anterior hyaloid membrane? I told you it is condensed part of the vitreous. Come to number 3. If nothing happens, the third modality would be go for pars plana vitrectomy. Okay, remove all the extra aqueous from the vitreous cavity. So pars plana vitrectomy. What is it? Why we say always pars plana? Because we enter the vitreous cavity through pars plana. So how do we know where is the pars plana? I hope you are very clear with this. It is around 3.5 millimeters from the limbus. So when I am giving intravitreal injection, I am again giving 3.5 away from the limbus. Keep that in mind because I want to go through pars plana, right? So that I don't damage the important structures. So whenever we are entering the vitreous, we would like to enter through pars plana. Okay? Okay, so that was malignant, and now comes a very interesting question again on malignant. See, normally what we have learned is in angle closure, which is the drug, which is the choice of drug to open the angle, it is pilocarpine, isn't it? Now, what do you really realize here? In malignant glaucoma, it is not the miotic, but it is the mydriatic which we are giving, which is treating the glaucoma. So when we treat this glaucoma with the mydriatic, we call it inverse glaucoma. It's an important cue, guys. Write down inverse glaucoma. So what you learned about reverse. Pigmentary is reverse glaucoma where the iris is concave. Now this one is your inverse glaucoma. So what is inverse glaucoma? Write down when we are treating the glaucoma is treated by mydriatic. So I want you to know two major examples of inverse glaucoma. One you have learned with me is malignant. This has been your exam question. And second you can learn is microspherophakia. Now spherophakias or microspherophakias, do you realize it causes glaucoma by creating a pupillary block? And because there is a pupillary block, if I am going to just dilate the pupil, the block opens here. Okay, so these are the two examples where we can learn for inverse glaucoma. Chalo. Now we come to the next secondary glaucoma. Which is the next secondary glaucoma? Give the heading, it is uveitis, glaucoma associated with uveitis. Glaucoma associated with uveitis. So we all know uveitis is a very comfortable chapter, I told you earlier also. So do we remember this, that synechia means adhesion, and during the anterior uveitis there can be adhesion between iris and lens and blocking the pupil? Correct? So if this happens, what is this? This becomes any block in the pupil can lead to angle closure glaucoma. We all know it so well. So one can be glaucoma due to uveitis can be angle closure glaucoma with pupillary block, right? Or it can even be when there is peripheral anterior synechia which is being formed. But actually that will always happen when there is a pupillary block, there is iris bombay and peripheral anterior synechia. So generally it is so, but we can say that it can be with pupillary block or without pupillary block. Later on, without pupillary block, mainly it is due to peripheral anterior synechia. Now coming to, but please understand, peripheral anterior synechia is happening why? Majorly without pupillary block. Major example if I ask you is always plateau iris which is doing it. But when I talk about uveitis, so uveitis is causing posterior synechia, it is with pupillary block, or it can even lead to anterior synechia formation, and that can be considered as without pupillary. Okay, then what is the third one? Third is your open angle glaucoma. It can lead to, not primary, so sorry, we'll write open angle glaucoma. Now how will the uveitis lead to open angle glaucoma? Common sense. Maybe then what is happening? That inflammatory cells in the aqueous, which are called aqueous cells, are draining into the trabecular meshwork and blocking the TM, isn't it? Okay, so this can lead to open angle glaucoma. This open angle glaucoma actually blocking the TM or sometimes even causing inflammation in the trabecular meshwork. So now comes a very important topic which is asked in your exam. I am talking about, I am repeating, with glaucoma associated with uveitis, which is open angle type, is mainly called glaucomatocyclitic crisis, or we call it PSS. This is Posner-Schlossman syndrome. Posner-Schlossman syndrome. Okay? I'll tell you one more name for this. We also call it hypertensive uveitis. That can be the another term. Please correct this. It is hypertensive uveitis, means wo uveitis where there is more intraocular pressure. So that uveitis with the high rise of IOP, mainly due to the open angle glaucoma. So when there is acute high rise, this is what is called glaucomatocyclitic crisis. The other name is Posner-Schlossman syndrome. It is also called hypertensive uveitis. Why I am stressing all three names? Actually, all three names, by all three names, they have asked you a question in your PG entrance. So there is a difference. If suppose the question is something like which drug do you want to select for a patient treated to treat glaucoma with hypertension. With hypertension means the patient has a problem of hypertension. There is a high BP. So common sense, I will not give alpha agonist, right? Then the answer is different. But suppose the question is what will be the treatment of choice or drug of choice or management in hypertensive uveitis? Now we are talking about that uveitis where pressures are more. We are talking about intraocular pressure. We are not talking about blood pressure. So be very careful. Is it uveitis with glaucoma with hypertension, uveitis with hypertension, or is it hypertensive uveitis? Okay? I doubt that these terms have been used earlier, but most probably these days what they are asking you is by the term Posner-Schlossman syndrome. So what it is? So this is mainly a disease seen in young males. Sabse pehle, what are the points to remember? Of Posner-Schlossman, this condition is generally common in young males. It is seen more in young males. Okay? And it is generally, why will suddenly this happen? They start getting a recurrent attacks of uveitis with more pressure. So why this is happening? So some HLA associations have been documented like HLA-BW54. I don't want you to learn this actually. Nobody has asked it yet. But yes, associations, why suddenly a young male will start developing? One is because of this reason, some genetic predisposition, or it could be, it could also be due to exposure to, one theory is exposure to CMV infection or H. pylori infection. So this is the thing why it is happening. So we only know associations, we do not know the exact cause. Now what is happening is that the signs of uveitis are minimal. So it's a condition which is very, very prone for misdiagnosis because you are not getting prominent keratic precipitates, but pressures are very high, more than 40. So very, very easily you can misdiagnose it as angle closure glaucoma. So if you misdiagnose it as angle closure glaucoma, you will start giving pilocarpine to open the angle. Pilocarpine aggravates uveitis, the condition will become even bad. Okay, so that is why it has so much of importance. So once you have written the etiology and association, pathogenesis you can write down. I told you it is mainly the trabeculitis which is happening due to uveitis and blocking of trabecular meshwork. This is all due to uveitis. Okay, recurrent cycles of anterior uveitis. Now, on examination, what are the findings? Very quickly, let's understand here. Draw the diagram, please. Okay, so few KPs as mentioned. The KPs are few. This one point we have to remember. The KPs are few. Okay, because there is no posterior synechiae. Generally, we don't see. We get a dilated pupil though. In uveitis, pupil is constricted, but here I am getting a dilated pupil. That can be a sign. Also a point of confusion why I misdiagnose it as angle closure glaucoma. And of course, no posterior synechiae. Just write down one more thing here. No posterior synechiae. Intraocular pressure write down is more than 40 mm. Now, so once we know that, and even redness, of course, we should also mention if it is a typical uveitis, it is intense. You see the eye very red, right? But here you see mild redness. Let me just show you the slide. See, this is Posner-Schlossman. Can we see the redness? Very mild redness. If I label this for you, I would just say it's a mild redness, little dilatation, right? Hardly maybe few KPs, but is not shown in this clinical slide. Dull, right? And do you realize something in this patient? Iridotomy has been done because it has been previously confused to be angle closure glaucoma. So peripheral iridotomy has been done. But this is not effective. The patient is again having the same problem of more pressures and uveitis. So he is again presenting with the problem, right? So this is your Posner's clause. What to do? So now comes the main confusing part here, how to manage. If I give steroids to manage uveitis, I raise the pressures, right? But if I don't manage the uveitis, if I'm not managing the uveitis, I will not be able to control pressure anyway, because the main cause is inflammation in the trabecular meshwork. So if this is the favorite question of your exam, what is the treatment of choice of Posner's Klaussman syndrome? We will always start with anti-glaucoma, try to decrease the pressures first. So anti-glaucoma drug is given first, and once the IOP is controlled, we start with steroids. So your answer should be that steroids are given under anti-glaucoma cover. Cover matlab, I start anti-glaucoma before starting steroids, like this. I have started already, then I start with the steroids, my anti-glaucoma is continuing, and I will finish the steroid, stop with the steroid, but my anti-glaucoma is, this is called undercover. So your answer should be steroids under anti-glaucoma cover. Okay? So that was Posner's Klaussman syndrome, important interesting topic. So now that was about glaucoma associated with uveitis. So we were talking about steroids, so let's also talk about next secondary glaucoma is steroid induced glaucoma. So when you say steroid induced glaucoma, we all know this, I have solved this, we have discussed this question in our lens chapter also, that the most common complication of steroids in eye is glaucoma. Which glaucoma? We have learned it is open angle glaucoma. I also mentioned to you all that this is due to more of the mucopolysaccharide deposition in the trabecular meshwork, more of the glycosaminoglycan deposition. We know trabecular meshwork has GAG, glycosaminoglycans, right? So this is mainly the altered function of the extracellular matrix. So main cause you can say, or pathogenesis out here is, it is an altered, write down, function of extracellular matrix, and because of that, what is happening is deposition of mucose polysaccharides in the trabecular meshwork, or GAG in trabecular meshwork. Naturally, that will block the TM, leading to glaucoma. And we also mentioned about the responders, high responders, mild, moderate and severe, high responders, right? So high, what did we discuss? You have started the steroid and the pressure goes above, the difference is above 15. Or it can be between 6 to 15, it is moderate, and less than 6 is mild. We should not give steroids at all in high responders. Otherwise, we are starting with another problem. Right? I am not writing this, we have written it before. We come to the next secondary glaucoma. Next is traumatic cataract. Do you remember we discussed this in the earlier chapter of traumatic glaucoma, I should say. Sorry, we are talking about glaucoma. So we had learned that any blunt trauma, if you remember, we talked about rosette shaped cataract, we talked about Berlin's edema, blunt trauma is also causing Hosier's ring. Now, in that line of thought, you have to continue thinking, apart from that, what blunt trauma can cause? Glaucoma. How? Either it is causing angle recession glaucoma. I'll just show you the slide. What is recession means? To go back, right? Piche khisak jana. So there's a tear in the ciliary body and there is angle recession. Angle recession glaucoma. Angle recession. Okay, first see the slide, then we will write, then you'll understand better. See this slide. So what you see here on a gonioscopy, what are we seeing? The arrows are showing you the torn iris and a broader white band, which is the scleral spur. So this is all happening. This is what is angle recession. Recession means what? Look here, what do you see here? The arrow is showing you that the angle is, there is a tear in the ciliary body and angle has gone back or piche. Okay, that is called recession. So now write down. So write down, recession is due to tear in ciliary body, but glaucoma is actually due to associated damage in the trabecular meshwork. Associated damage in trabecular meshwork. So that is one cause of traumatic glaucoma. What is the next? Next would be It can be due to any trauma is causing hyphema. What is hyphema? Blood in the anterior chamber. Now, blood in the anterior chamber, the two important red flags which come in mind is, okay, it can cause glaucoma, and very, very important, if it is a total hyphema, it can actually stain the cornea, which is very, very serious complication. Corneal staining is permanent and we can do nothing about it. You have to replace the cornea. Okay, so that's why it should be quickly replaced. Okay, so these are the two major things that come in the mind. It can lead to corneal staining, and this is a permanent problem. It is irreversible. Okay, we don't want this to happen ever. And of course, it is causing glaucoma. Now, what are the glaucomas a hyphema can cause? We have to be familiar with the terms. So, hyphema can be partial, as you see here, right? Or it could be total like this. Can you see this? Now, this is a big risk for corneal staining, as I told you, right? Now, when the blood is in the anterior chamber, what are the different ways by which it can actually block the trabecular meshwork and lead to glaucoma? So, please note down this one, all of you. Red cell glaucoma term we use when the block is, it is the RBC which block. It is more theoretical, but just be familiar with it. Hemolytic glaucoma term is used when it is the macrophages which engulf the RBC and then block, it becomes hemolytic. Okay, so red cell is RBC and hemolytic means it is mainly the macrophages which engulf. And third is hemosiderotic due to iron and hemoglobin, right? That is hemosiderotic. And what is ghost cell? This is interesting and important. This was your exam question. Make a cue here. Ghost cell means, first understand what I am saying, then you write. So ghost cell, what is happening? If there is a vitreous hemorrhage, so what happens that RBC loses its hemoglobin, iron, and these cells are ghost cells. Slowly these ghost cells are traveling anteriorly and they are blocking the trabecular meshwork, and this is what is called ghost cell glaucoma. Okay, so ghost cell glaucoma has been your exam question. Please put a Q there. Okay, hope you have noted down. Yes, so we next come to the next secondary glaucoma. It is ICE syndrome. What is ICE syndrome, all of you? It stands for iridocorneoendothelial syndrome. Okay, iridocorneoendothelial. Common sense, some problem with the corneal endothelium and the iris. So everybody should know this, that in a normal circumstance, endothelial cell of the cornea never proliferates. ठीक है? अब क्या हो रहा है? What is happening in this? What is happening in this is that these endothelial cells start proliferating. So when the endothelial cells, they start proliferating, naturally it can encroach the angle. There is also some associated fibrotic activity there. This is going to lead to closure of the angle. Okay, all of you. So what is happening? When we will, what do you call that? Proliferative endotheliopathy. Okay, so it's a proliferative endotheliopathy with secondary glaucoma. If you answer this, perfect. It's a proliferative endotheliopathy. Write down please, with secondary glaucoma. Okay? Okay. Now this, once you know this, what is ICE syndrome? What are the few more points we will remember? First of all, it is more common in mainly a disease of middle-aged women, right? And generally it has a commonly unilateral presentation. Okay. Now, sometimes it has been associated with viral infection, like herpes simplex. Herpes simplex virus. Now this disease has three main forms and you have to be familiar with the terms. One is your Chandler's syndrome. Easy to learn? Everybody is remembering, friends? Huh? Chandler's syndrome. Yeah. So again, Chandler's syndrome, it is the same proliferative endotheliopathy with secondary glaucoma. I am seeing all these things. Now, which is the one major prominent feature we will discuss apart from this? We cannot discuss the list in each, we don't need to. So one major prominent feature in Chandler's is corneal edema. Okay, we will learn corneal edema. And keep writing below, Chandlers. This is the most common form of IC syndrome, and the cornea is generally described as, we will be just familiar with the term please, we will call it hammered silver appearance. I'll show you the slide. Hammered silver appearance. Okay, so that was Chandler's. Come back to the next one. Progressive iris atrophy. Now when you say progressive iris atrophy, common sense, what is the prominent feature here? There is iris atrophy. If there is iris atrophy, do you realize you can have another pupil? More than one pupil is polychoria, but this is mainly due to atrophy, so we call it pseudo-polychoria. Okay, so our next, we will say, in this case, you are getting a pseudo-polychoria. And what else? It can be correctopia. When the pupil is shifted towards normal side of the iris, you can call it, it is not central anymore, we call it correctopia. Okay? Now we come to the third form. The third form is Cogan-Rees syndrome. Right? What is Cogan-Rees syndrome? Again, it is the same IC syndrome, proliferative endotheliopathy with glaucoma. Prominent feature bolo, we will say it is nevus and nodules in the iris. So what you see in the iris is nevus, nodules and irises. Okay, these are the things which are seen in the iris. This is about your Cogan-Rees. Right? So this much we will know about IC syndrome. Correct. So these are the important list of some important secondary glaucomas that you have to know. IC was once an exam question. I think it is single Q, not a double Q, but yes, it is a Q. You have to know it. Chalo. After this, we talk about is treatment of glaucoma. Finally, we reach to the treatment after a long journey. Chalo. Treatment of glaucoma, we will broadly divide as, it can be medical, it can be laser or surgery. Easy? Life is easy? Medical, we talk about anti-glaucoma drugs. An anti-glaucoma drug can be either topical or systemic. Now, topical one is so very important with so many questions. Now, before I go to these drugs, let's talk once more about IOP. We know that majority of the time more IOP is due to more amount of aqueous, and more amount of aqueous is either due to more formation or less drainage. Okay? Everybody is clear about this? We also know that majority of the time it is the less drainage which is the cause of glaucoma. Okay. So what are these anti-glaucoma drugs actually doing? So anti-glaucoma drug, common sense, it has to, all these anti-glaucoma drugs are aimed at decreasing the amount of aqueous. And if I have to decrease the amount of aqueous, either there should be less formation or it should be more drainage. Again, majority of them is acting on drainage. Is this absolutely clear? So this is what anti-glaucoma is doing. That is to decrease the pressure, and for that it will decrease the amount of aqueous. And how to decrease the amount of aqueous? Either less formation or more drainage. Okay. If you are clear with this, tell me one thing. Mainly it is the more pressure and more amount of aqueous. Is there any role of these drugs in normal tension glaucoma? I think I mentioned this before with you. So I mentioned to you all that yes, there is always a role. In normal tension, the cause may be vascular. IOP is normal, no? I'm just trying to ask you this, that okay, what is the role of anti-glaucoma then? IOP is already normal and all these anti-glaucomas are just managing the IOP. But still there is a role. Why? Because the normal range of intraocular pressure is very large. It is from 10 to 21. So if your patient is a normal tension glaucoma where the pressures are almost normal, I will still want the pressures to be on the lower side of the normal. Got it now? So what is the concept of target IOP? Before I come to these drugs, how do you define target IOP? Now if you write down. So target IOP is that IOP which prevents the progression of the visual field defects. Now, which prevents any progression of visual field defects without compromising the quality of life. Without compromising. Okay, so this is how you are going to define what is target pressure. Chalo. Now we'll talk about topical drugs one by one. Very important. I've already put a double Q there. So topical drugs, first is your beta blockers. Give the heading beta blockers. What is the mechanism of action, all of you? This decreases formation of aqueous. It decreases formation of aqueous. Okay. Then, what are the names of the beta blockers? We will learn timolol, betaxolol, levobunolol, etc. Okay? Now, what are the questions are? Beta blockers are contraindicated in, we all know, asthma. It's a more of a pharma question. Second question. Which drug causes nasolacrimal duct obstruction? Please keep making the cues. We will answer timolol. Nasolacrimal duct obstruction. What can be the other side effects which you should also remember? It can lead to, other side effects can be corneal anesthesia and blepharoconjunctivitis. Now see, blepharoconjunctivitis is caused by alpha agonist also. So if there has been a question where both timolol is also mentioned, alpha agonist is also mentioned, right? So if that is so, we should answer alpha agonist. So even that apraclonidine causes the most of the blepharoconjunctivitis, then brimonidine, and then comes the timolol. So allergic blepharoconjunctivitis. This was also a confusing question asked so many times. Which one to mark? Both are correct. So I'm telling you, you should mark alpha agonist. So that was your beta blockers. We come to the second group of drug is alpha agonists. Mechanism of action. What is the mechanism of action here? It either dual action. First keep in mind it has a dual action. It is doing both the things to decrease the amount of aqueous. It is increasing the drainage and it is decreasing the formation of aqueous. Increasing drainage, decreasing formation. Which drainage? Please remember it's the uveoscleral outflow. Which drainage? We will answer uveoscleral outflow. Okay? Okay. Then we talk about is what are the names? Of course, adrenaline, which is also called epinephrine. This is same thing, adrenaline or epinephrine. Then we can learn about dipivefrine. Then some selective ones are, we all know, brimonidine and apraclonidine. Right? Great. These are the selective alpha agonists. So we can give in hypertensives and heart disease patients. That means normally these are contraindicated in hypertension and heart disease. But selective one can be given. Then a few more questions on alpha agonists. We will keep writing, please. Very important cue. Which drug causes drowsiness? Which anti-glaucoma drug causes drowsiness? We all know it is brimonidine. Which anti-glaucoma drug is contraindicated in children? Again, we know it is brimonidine. Why brimonidine? Because brimonidine can cause sleep apneas and also it can lead to heart blocks in children. Okay, so why? Because it is CNS depression, sleep apnea, lot of problems, heart blocks. Don't give in to small infants. Then we talk about the third question is, which anti-glaucoma can be given in pregnancy? Given in pregnancy, allowed in pregnancy is again brimonidine. Keep this in mind. So 3 questions on brimonidine. And which anti-glaucoma can cause lid retraction? Primarily we are talking of apraclonidine. It is apraclonidine. Still we are not finished. More questions here. They have also asked you about that conjunctival deposits or conjunctival pigmentation. So don't answer latanoprost. Latanoprost causes iris pigmentation. Here the question is conjunctival. Actually these are deposits, not pigmentation, but the question was like that. So we will learn in both with both the terms, pigmentation or deposits. What is the cause? We will answer adrenaline. Primarily it is epinephrine or adrenaline. We should also remember that adrenaline can lead to cystoid macular edema. This is a specific side effect of this drug and therefore contraindicated in aphakic glaucoma. Means a patient with no lens, aphakia, if you are treating his glaucoma, don't choose this drug. This is what it means. This is a very important cue. I made a bigger one. Okay? So this is aphakic glaucoma. We will not use it. And then we talk about another very important point regarding adrenaline. Of course, we have already mentioned that any non-selective should not be used for in hypertensives and in heart disease patients. Done? Okay. That was about this group of drug, alpha agonists. Come to the next group of drug, miotics. Okay. What is the role of miotics? Miotics, of course, mechanism would be it increases trabecular outflow. Remember, this is important. This is one drug which is increasing trabecular outflow. And second part, of course, in cases of it can open the angle in angle closure. By meiosis, it opens the angle in angle closure glaucoma. This we know very well. Name generally what we use is pilocarpine. Right? So what can be the side effect of pilocarpine? We'll make a diagram and learn few side effects of pilocarpine. Okay, so again start thinking it is causing meiosis. So when it is causing meiosis, do we realize something? That it will be also leading to spasm of the CVD muscles. So what is happening? We had discussed accommodation. So any spasm of CVD muscle contraction of CVD muscle can cause more curvature of the lens, which means more power, right? And when there is spasm in the CVD muscle, this can lead to what we call, we'll just label here, pseudomyopia. There is constriction of the pupil or meiosis, but what is that is normal. This is not a side effect, but what is the side effect can lead to this. And of course, another important thing, there will be shallow anterior chamber. There can be iris, in the iris there can be iris cysts. And when there is too much of the accommodation, spasm and contraction of ciliary muscles, sometimes it can even lead to retinal detachment. It can also be a risk of retinal detachment. The lens iris diaphragm, it is moving forward, right? Because the lens iris diaphragm is moving forward, I am getting shallow AC. Okay? I can get iris cysts. I can get pseudomyopias. And of course, because it is actually a mediator, it increases the capillary permeability. A major, it is also causing uveitis. Therefore, this is contraindicated in uveitis. Please remember this is asked. In the box, all of you make a cube. So, pilocarpine will be contraindicated in uveitis. Great. Done here? Okay. So, this was your miotics. After miotics, next we will learn is PG2-alpha agonists. Okay. What is the mechanism of action? This has been a double Q of exam. The mechanism of action is it increases the uveoscleral outflow. It increases the uveoscleral outflow. Please remember this, very important. And of course, it's a mediator of inflammation, so we can also keep this question in mind. It is contraindicated in uveitis. What are the names? Latanoprost. We'll discuss some few questions here. Then bimatoprost. What else? Travoprost. Right? And one more is uniproston isopropyl. or tafluprost. The new one is tafluprost. And lastly, uniproston isopropyl. Okay? Now, it is contraindicated in uveitis, this we know. Please also remember we should also avoid in asthma. So avoid these drugs. We can write anywhere here. These are avoided in clinical asthma. So I was saying that it is a general impression that okay, what if I'm, of course the systemic side effects are less if I'm giving a topical drug. But I think it's a very strong message here when we are learning anti-glaucoma. We know that it definitely affects systemically, right? Yeah. Anyway, let's come to the next important point is they have asked you a question. Again, Q's and more Q's. Which anti-glaucoma causes heterochromia iris? What is heterochromia iris? Difference of iris color between the two eyes. And we know the answer is latanoprost. So latanoprost can cause HI, which is heterochromia iris. This is difference of iris color between the two eyes. Right? So this is caused by latanoprost. Why? Because it causes iris pigmentation in the eye in which you are putting it. That will lead to that it is causing iris pigmentation. Come to the next question. So they have also asked you which drug can increase both outflows. I'm going to tell you one more drug in the newer drugs of glaucoma. But otherwise, if they ask you both outflows, you will answer bimetoprost. By both. Both trabecular outflow and uveoscleral outflow. Okay? So this is one drug which increases both outflows. Another important side effect of these prostaglandins is hypertrichosis. I'm going to show you the slide. So more growth of the hairs, especially the eyelashes. So hypertrichosis specifically is caused by bimetoprost. It is more prominent because the concentration of bimetoprost is maximum. Anyway, so it is mainly or any PGL. In that case, any PG alpha 2 agonist, all these PG analogs can lead to hypertrichosis. Okay? As I told you, it is more prominent in bimetoprost and it is actually an FDA approved drug for hypotrichosis. Keep that in mind. So these are the questions asked from PGF2 alpha agonist. PGF2 alpha. Sorry, you write this PGF2 alpha agonist. Next, we talk about which is the next anti-glaucoma, carbonic anhydrase inhibitors. And this time we are talking about topical drugs. So topical carbonic anhydrase inhibitors. Carbonic anhydrase inhibitor, what does it do? We all know this. It is going to decrease the formation. Mechanism is decreases formation of aqueous. It decreases formation of aqueous. What are the names of topical CA inhibitor has been your exam question. We should know it can be dorzolamide, it can be brinzolamide. Topical names are not acetazolamide. So dorzolamide, brinzolamide. Okay, another very important question. It is a sulfonamide. So it is contraindicated in sulfa allergies. Please remember this was asked in the exam. It's a Q. It is contraindicated in sulfa allergies. Okay? Okay. That was about your CA inhibitor. Then we come to, apart from these topical drugs, let me also mention the newer topical drugs, newer anti-glaucoma drugs. In the newer anti-glaucoma, the first that you will know, very, very important, is netarsodone. Right? This is given as 0.2%, 0.2%, and it is given in an OD dose. Even prostaglandin generally given OD dose, and preferred time being 9 p.m. So sometimes commercially also the eye drops, the Latanoprost is available as a 9 p.m. eye drop. Okay, so that is maybe OD. So we were talking about netasodil. So netasodil is a RHO kinase inhibitor. Okay, so it is an RHO kinase inhibitor. Rho kinase inhibitor, right? And that is ROC, we call it in short. So mainly it is available with the name of Ropresa. Now I'm going to tell you mechanism of action is important and one side effect is very important. Coming to mechanism of action, did we remember how the trabecular meshwork has got actin and myosin? What is netasodil doing? I have mentioned there also. Because Rho enzymes, they actually increase the rigidity in the actin myosin. Ropresa is an inhibitor of these enzymes, and therefore netasodil, what it is doing is, it is mainly, you can understand this way, increases the contractile property of the trabecular meshwork. That's simple. Okay, this will be more than enough. Contractile property of trabecular meshwork. And apart from that, okay, so apart from that, it has also been seen to decrease some aqueous production. So decreases production also, but prominently it is doing this. That means it is increasing which outflow? If it is increasing the contractile property of TM, primarily it is increases the trabecular outflow. So I want you all to remember this, that the two drugs which increase the trabecular outflow, one was pilocarpine and second is this one, that is netasodil. Okay? Yeah. So other actions can be that it can decrease the aqueous production, that is one contribution, little bit contributing to less aqueous formation and also little bit contributing to less episcleral venous pressure. So decreases, this is a little extra point, if you don't want to take it, it's okay. RO inhibitor is very important, you have to know this RHO, right? So it decreases the episcleral venous pressure. These are the main mechanisms of netasodil. And what is the side effect? Now, side effect is one very important side effect, which is very, very important to ask in the exam. It can cause, it get deposited on the cornea in a whirl-like manner, and this is what is called, we learn it in the cornea, this is what is vortex keratopathy. We'll come to the slide shortly, let me finish this. So, vortex keratopathy, which is also called cornea verticillata. So, we will remember this as one of the causes apart from some other drugs. I'll take this in detail in cornea chapters. And what is the next new drug? Apart from one netasodil, the second topical new drug we will learn is latanoprostene. So, it's a combination of two drugs. So, latano is increasing latanoprost, so it increases the uveoscleral outflow. Okay? And when you talk about prostene, okay, full name is latanoprostene bunol. So what happens? This is releasing, it is NO donating compound. So nitrous oxide increases the, so this compound increases through NO, is increasing the trabecular outflow. If you don't want to remember too many stories, it's okay. Just remember two drugs where both the outflows are being increased. One was bimetoprost, second is latanoprostene bunol. So latanoprostene bunol is not available in India. We don't expect that question on the PG entrance, but netasodil can be asked. Okay? Yeah. So this was about topical drugs, and now we come to the systemic drug. Systemic anti-glaucoma divide into two. One, again, carbonic anhydrase inhibitor. And this carbonic anhydrase inhibitor, we will answer is, we are talking systemic. So, acetazolamide or methazolamide? Acetazolamide or methazolamide. Right? Again, the same things apply here, that this is contraindicated in sulfur allergy. Of course, mechanism of action is same. Decreases formation of aqueous. Now, very important, when you are giving it systemically, there are some even disturbing side effects of acetazolamide, Diamox tablets. So, generally, what are those side effects? Tingling and numbness. Please remember this. Tingling and numbness, constipation, very common and prominent, and there can even be renal stones. These are some of the more prominent signs. And yes, a bad metallic taste. So imagine a person having tingling, numbness with constipation and bad metallic taste. Very miserable condition, right? So bad metallic taste. Now what was the second? The second systemic drug we will learn is hyperosmotic agents, right? So hyperosmotic agents are going to draw the water out from the eye and therefore decrease the pressure by becoming more hyperosmotic or compared to the aqueous, right? Or compared to the intraocular fluids. Therefore, it almost like dehydrates the vitreous. So, hyperosmotic agents, what we can use IV mannitol. We have mentioned that earlier also. So, one is mannitol, but you can't give mannitol in heart disease patients or kidney failures, right? You have to be careful. Then, second hyperosmotic is glycerol, but you can't avoid it in diabetics. Then, isosorbate and urea. Isosorbate and urea. So, these are the hyperosmotic agents, right? Okay, now let's see the slides. Yeah, I forgot to show you the silvered hammered appearance of the cornea in case of Chandler's syndrome. So, this is the silvered hammered appearance. Least chance that this will be asked as a clinical condition. Okay, so treatment we already have discussed about the target IOP. Now here, what do you see in this? Look at this eye, left, this one is the right. Can we see this is more darker? So the latanoprost has been put on in the right eye, which has led to heterochromia iridis. So you are looking at heterochromia iridis due to latanoprost. Look at this one. What is this? Look at the eyelashes. Can you see this? This is hypertrichosis, which is a side effect of PG analogs, most prominently biometric. What do you see in this one? I think everybody will answer me. That in this patient, the left eye, the lid position. So I hope you all know this, that what is the normal position of your lid? It is covering 2 millimeters of the upper limbus and lower lid is just touching the limbus. So when the lid is going above its level, this is what is lid retraction, and when it is going below, this is called ptosis. We'll learn in lid also. So here what you see is lid retraction. And lid retraction, what did we learn? Main side effect of apracloridine. Right? Very, very clear. These are the conjunctival deposits at adrenaline. Right? These are the conjunctival pigmentary deposits. Yes, whirl-like deposition of the drug. This is what is vortex keratopathy. Vortex keratopathy kahan pada tha? What did I say? So we have number of causes of vortex, chloroquine, albuterol. We'll talk about it in cornea. Here we will learn this is also a side effect of nitarsodine. It is also a side effect of nitarsodine.